All right, all here? Yes? Great. Good morning, everybody. Want to take the next 40 to 50 minutes or so to talk about a topic that is near and dear to my heart, right? The medical consult. And hopefully by the end of this lecture, it'll be near and dear to your heart as well, if it isn't there already. This is something that I think, right, we deal with every time we work potentially. And the idea of this discussion is to really set you guys up for success during the medical consult, to provide you and review with you a framework for how to approach even the most difficult medical consult based on a variety of factors that we know make things very, very challenging for us out there. So what I want to talk about today is right here up on the screen. We're going to start by talking about indications for consulting. We're then going to go into our rapid consult matrix. We're going to talk about tips for how to stay organized, review some keys to success, talk about the do's and don'ts, and then we're going to go upstairs, break up, and review some cases. Okay. Spoiler alert. Please, 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 please utilize what I'm about to talk to you about when we go do the small groups upstairs. It's a really good way to do very, very well on the small groups. Literally apply what we're about to talk about upstairs, and you will have no problem whatsoever. This should not be new to anybody. This is directly out of our protocol book, inclusion criteria. So when we're doing a medical consult. Okay. So one thing that I wanted to sort of further explore is this number 3 right here, and we'll blow it up. So you're at an outside facility. You have assumed patient care, right? You have gotten a report on the patient. You started to evaluate the patient. You started to switch over equipment. And there is something that either you feel the patient needs or you would like to discuss, and the sending physician is there and gives you orders to do something, or asks you to do something, or you feel like you want to do something, but it requires physician consult for it. Okay? Even though you're at that sending facility, that call should come to us. Okay? Once you have taken over care, once you have received report, all further medications, plans regarding patient care occurs via the medical consult if it's appropriate based on our protocols. Obviously, we all know that if there's something that somebody asks you to do that is outside your protocol, clearly you call for that. But really, we should not be taking direction in orders from that sending facility physician once we have established care of the patient. We should run it through our medical consult line. Again, this should not be new to anybody. This is directly out of the protocol. Other reasons to consult: unstable vital signs, as you see listed up here, that are unresolved by your protocol-based interventions. Clearly, any diversion, right, or unplanned stop. Our dual consults with pediatrics. Obviously, all the reasons that are outlined within the specific protocols. And obviously, we want you to keep an eye on their bedside times. If we're feeling like our bedside time is going to exceed an hour, it's a long time, right? It's probably a good reason for it, but we want to know about it so we can help facilitate movement of that patient out of the door. How can we help you get that patient out? Then obviously, given all the PPE that's associated with our COVID patients, we extend that a bit to a 90-minute window. All right, let's open it up to a little bit of discussion here. Why are consults challenging? I don't think anybody here just jumps at the opportunity to do a consult, right? Why are consults challenging? Why don't we like to do them? Great. So you're expand upon it. I know what you mean. Expand upon it. It's awesome.
There you're trying to get the patient on our stuff, get them here as quickly as possible. You're not adding to that time by having conversations
Well said, right? So competing priorities. You're having to take care of a patient. You're having to assimilate data. You're having to treat the patient. You're having to come up with your own plan of care. You're having to have discussions with people at the outside facility. You're having to talk to members of your team, right? These are all things that you need to do. So how do you basically get that consult in there without delaying getting the patient out the door and to definitive care, which is where they need to be? Well said. Great. What else? Anybody else? One other thing out there. Yeah, right? Like, now lucky for us, most of our consulting physicians work nights, so you're okay there. But yeah, you're right. Like, the I don't want to bother you factor is real, right? Whether it's for this group here, we see it with residents who don't want to wake up their attendings in the middle of the night, so things get pushed, right, to the morning. The I don't want to bother you factor is real. We are on call, okay? We are here. Please bother us when it's appropriate. Other reasons. So the information that you're getting may be limited. So you don't, right? You only have a little bit of information. How do you then put that into a coherent and cohesive consult? Or the information you're getting is overwhelming, right? Have you ever walked into a room and all of a sudden, like, boom, somebody unloads information on you and you're not quite sure how it's relevant to your patient in front of you or when it becomes relevant, and the person providing you the history could probably be doing a better job doing so. The environment may be challenging. Okay, so forget the fact that you're constantly potentially in the back of an ambulance or an aircraft, right? Often the environment in the sending facility is challenging for a number of reasons. Your resources obviously may be limited to do what you want to do, and the patient could be medically complicated, right? This is probably one of the number one reasons you're taking a very complicated, very sick patient with a lot of data and a report that may not be ideal, put it together and try to make something out of it, right? And this is a life we live, right? Like, not bad. Have you made that face before? Right? We've all been there. I think everybody in this room has been there. I've been there. Okay? We all get it. We've all been there. But what's your plan? What's your plan when you receive a report like that? Because you are still expected to deliver the same high quality, high level of care on that patient as any other patient, right? Well, obviously somewhat corny, that's what you're expected to do, right? Take a bunch of lemons and make lemonade out of it. So how do you do that? I want to hear from you guys. How do you take a report or a bunch of lemons and make some lemonade? Because that's what we're called to do. We are called to transport a patient when typically they've exceeded the capacity, the ability of that outside facility to take care of them. They are calling you for help. Sometimes it doesn't look like they're calling you for help, right? And sometimes you ought to say, help me help you. But they are actually calling you for help. What's your plan?
For assessment, since they might not be used to taking care of that acuity of the patient, so they might be overwhelmed and be given more information.
I love that idea. It sort of distilled down to the idea of trust but verify. Listen to what they are saying, but verify the information you're getting is accurate. And always, always doing your own assessment and come to your own conclusion. What else? Prioritize. How do you prioritize? That's great. Making a priority list is key. And a way to do so is sometimes making a problem list. So when a lot of information becomes overwhelming to us, or the information you're getting is somewhat haphazardly given to you, the way to sort of maintain order in that is to develop a priority list based on the problems that you have identified for your patient. And then based on the problems, what your plan is to address each one. Great. In general, very important things to remember. Our outfits are not subtle, right? We wear purple. We are easily identified. If the purple doesn't do it, the Johns Hopkins Critical Care Transport Program does. We represent this institution, okay? Obviously, we always remain professional. And that's not just with what you say, but all of these other nonverbal cues that you give to people, those facial expressions. I don't care that you're wearing a mask, okay? It doesn't matter. Rise above, stay professional. Watch your facial expressions. To Tristan's point back there, stay goal-oriented. Identify your priorities, identify a problem list, identify a plan. What I like to call, don't be distracted by entropy. What is entropy? Anybody? Randomness, random order, right? You've walked into these rooms before and it's this like vortex of randomness and drama and all of this stuff going on. Don't get sucked in. Don't get sucked into it. Rely on each other. Work as a team. Huddle up. Figure out where your priorities are. Develop a plan of attack and go execute it. And then a really important thing that I think some of us struggle with, both in just the patient care aspect, but really in conveying the information, is a concept of losing the forest for the trees. Somebody tell me what that means. Yeah. Great. So there's a patient. That patient is not a lab value, right? Or a test result or a diagnosis. It's the patient. Good. What else? And sometimes we lose the big picture because these patients are so complicated and they may come with so many problems that we're talking about this problem and that problem and this problem and that problem, and we're losing the big picture. What is our main objective? Why are we here? What are we trying to do? Right? At some point, you feel like this, right? Help me. Okay? You're throwing that like out. We're going to catch it for you. We are here to help you. But as I said before, now your job is to help me help you. So let's talk about how we do that. This is, I think, a very telling quote that is really at the center of a lot of issues that we see with problems in communication. George Bernard Shaw said, "The single biggest problem in communication is the illusion that it has taken place." Think about that for a second. And when that is applied in a situation that you are in, whether between team members, receiving a report, communicating with a medical director, you think you say something, I don't hear it. You say something one way, I hear it a different way, right? There are many sort of interpretations to that, but I think the overall concept is really important. So, what are tools for success that will allow us to be better communicators, right? And that's where this rapid consult matrix comes in. And we utilize the SBAR tool, which is not something that we developed here, right? It's a pretty well-known communication tool that is used throughout the healthcare community. And it's utilized because it works. What does it stand for? Situation, background, assessment, and recommendation. Now, depending upon what your job is and what your role is, obviously this takes on a little bit of a different meaning within each of those parts, but the overall concept is the same. Again, we refer to that as our rapid consult matrix. This is here for you, right? Spoiler alert, when you go upstairs and do these small groups, use this matrix. And use it today on a call, and tomorrow on a call, and next year on a call. It is here for you. Please utilize it. Let's talk about a little bit of history, right? Why do we use this? Because it facilitates prompt, concise communication between individuals. There is a predictable flow of information. You know what you are about to say. I know what you're going to say. It's super helpful. It ensures that important information is transferred accurately between individuals, and like I said, has become a popular tool in the healthcare community. So like many things that we now have in the healthcare community, we have borrowed, borrowed's the right word, stole from, maybe borrowed from a different industry. Anybody know what that is? Aviation. Aviation is one, and what's the other one? Very good. So where do we think this came from? There we go. Right? So first developed by the military for communication with respect to nuclear subs. Probably a pretty important thing to get communication right. It was then used by the aviation industry, and it is now utilized within the healthcare community, both by rapid response teams who need to communicate, obviously, important information quickly between one another, and really others in the healthcare community as well. Let's go through each part. Situation, a concise statement of the problem. We'll break each one of these up in a minute. Background, this is the pertinent information that is related to the situation, or in other words, the reason why you're calling. Assessment. There's a couple parts to this, and this is where I think we could tweak things a little bit to become even better. So what do we want to see here? What you found, and what you think is going on, and what you did. You are the bedside clinician now. I'm relying on you basically to make an assessment of what is going on, to tell me what you're worried about, to tell me what your plan is, to tell me what you have done. It's all really important. And then, of course, we get to the recommendation part, which is really, again, why you're calling, and the actions that, or the orders that we give you. Here it is all together on the screen. All right, so let's break down each one for a moment. So we start with who you are. Is it an SCT or an ALS or a BLS call? And the reason for the consult. If we as a medical director group can stress anything, it would be this right here. Reason for the consult. Why are you calling? The other way to think about it is what we call bluff. Anybody heard of this before? Bottom line up front. Up front, right at the beginning of the consult. Not a minute, 2 minutes, 4 minutes, 5 minutes down the road. This is so-and-so. I'm on an SCT transport. I'm calling for discussion about blood pressure management. I'm calling to discuss ventilator management. You go on to talk about where you're coming from, where you're going, okay, where you are, what your transport time is. We want to know right up front why you're calling. Calling to discuss acute change in mental status and plan for initiation of hypertonic saline in a patient with a head bleed and now concern for increased ICP. Bottom line up front. We then move into the background. Reason for the transfer, age, weight, gender, pertinent past medical history. Not everything, obviously, but what's pertinent. The diagnosis or diagnoses and chief complaint. What has been done already for the patient. What are the pertinent vital signs and any important trends with them. Vascular access, airway status, and ventilator settings. Okay. Another thing to pay attention to here is that these are numbered. Maintain this order and numbering for the consult. We miss things, it's distracting, it's hard to follow. When we talk about the reason for the transfer, then go to the vent settings, then come up to the past medical history, then go to the airway status, right? This is numbered for a reason. Follow the numbers. As part of this background, when we talk about pertinent vital signs, these are the ones we want to hear, right? And again, have there been any significant changes or trends? All of them. I will say the NIH stroke scale, obviously only when we're transporting a patient, right, who's received TPA, who's going for a thrombectomy. This is not asking you to perform an NIH stroke scale. This is, what was the NIH stroke scale of the patient? When it comes to ventilator settings, we want all the ventilator settings. Mode, tidal volume, rate, PEEP, FiO2. Not only do we want that, but what else do I want to hear from you? Great. What else? Right. How the patient is interacting with the ventilator. So important. There you go. All that information needs to be there. Let's take a look at the assessment part. Again, this is the area where I think we could tweak a bit to make even better than we already do it. Pertinent positives, negatives from the patient assessment and the interventions provided. Pertinent labs, radiology or EKG findings. What the fluid status of your patient is and what the I's and O's have been. So much of the medicine we provide relies on understanding what the fluid balance of the patient is. Do we start pressors? Do we give more fluid? Do they need diuresis? Do they need more volume? That is very hard to figure out without having an understanding of what the current volume status of your patient is. And directly related to that is, what's their I's and O's? I want to talk a little bit more about the lab and imaging data. You're going to be given a packet that sometimes looks like this, right? Or you're going to be given every lab that has been done on that patient. Your job is obviously to report the data or the labs that are relevant to what is going on with the patient. And that requires, obviously, an awareness of the diagnosis and the problem. An example of not losing the forest for the trees. I don't want every little tree, but I want a couple of trees that are based upon the big picture. So let's drill this home for a second. If we're talking about a patient with an intracranial hemorrhage, what lab data are you reporting during your consult? Say it louder. Coags. What else? Coags and, right, if it's related to any sort of anticoagulation that they're on. Okay? Coags. What else? Sodium. Great. What else? Glucose, great. What else? Okay, end tidal. That'll be part of your vitals, but yes, great. Absolutely. What else? Another one up there. What governs or plays a role in bleeding and bleeding time in a patient? Platelets. Okay. Hearing the potassium on that patient, obviously unless it's abnormal and outside our range, which would require you to report it, is not relevant in that case. It allows you to be succinct and purposeful with the information you give. Another important one to discuss is the blood gas. Right? This one becomes notoriously difficult for us sometimes. When we go to an outside facility, a patient is either intubated or not, but there's a blood gas done. Blood gases can be useful, but what do you need to tell me in addition to reporting the blood gas? When it was done, right? How often have you come to pick up a patient, the blood gas was done 6 hours ago? Is that relevant? Probably not. But it is important to say, there's a blood gas on the patient, it was done 6 hours ago, I don't think it's relevant. Do you want to hear it? I can say no. Okay? What else do I want to know when you report a blood gas? Other than when it was done? Pre or post intubation, exactly. You need to provide the context surrounding the lab that you're reporting. Because a lab value in isolation is meaningless. It just results in more confusion, more questions, and distracts from your objective. That's absolutely. I'm going to say, give me another one. You already did, right? Bruce said vent changes. Have there been changes between this one and this one, right? The last one and the current one. What were those vent changes? Because how are we going to know what to do next if we don't have an appreciation of the context for which that blood gas was taken in? Very good. Imaging, right? Again, using our example of the patient with a head bleed, I would expect you to report the CT findings. And not only report the CT findings, but again, give context. When was it done? If there is a change in mental status of the patient acutely, how does that compare to when that imaging was done? Not a great X-ray quality, I'm sorry. But we do have a positive arrow sign. So when would you talk about this X-ray? If you're transporting somebody with a what? Very good. Why? Excellent. She said balloon pump. We see the appropriately placed balloon pump between the second and third intercostal space. This needs to be conveyed. And then who wants to talk about this one here? When would you report this X-ray finding to us? On a patient who's intubated. And why particularly in this case? What do we think about the placement of the endotracheal tube? Yeah, say it again. Say it with confidence. It looks pretty high. Where's the carina? The carina is here, right? Obviously my fingers are not a measuring tape. But usually when the end of the endotracheal tube is sitting at the head of the clavicles, right, it's probably a little bit high. This should be 2 centimeters above the carina. It's probably more like 4 or so, maybe a little bit more. How comfortable would you feel moving this type of patient? Probably less comfortable than you would if the endotracheal tube was positioned properly. But this is directly relevant to that patient who you're transporting. Recommendation. We end with the way we started. We restate the reason why you are calling. Again, I'm calling to discuss concern for change in mental status, administration of hypertonic saline, for a patient who I believe now has elevated intracranial pressure. We give you that recommendation regarding the plan of care, and then you finish out with good closed-loop communication. So we are ensuring that you are hearing what we wanted you to hear. All right, we are not always super elegant in how we say things either. Right? So maybe we said something that was confusing or didn't come across the way we intended it to. The only way we know that is if we hear the way you heard it. Closed loop communication. Ultimately, your goal is to paint a picture of what is going on for us. There are some times when a picture may be helpful, right? Instead of trying to talk me through the way the balloon pump waveform is looking, maybe we take a snapshot of the balloon pump with the waveform. The ideal way to do this is securely, a HIPAA-compliant, secure manner, and something like secure chat would be a way to do this. Right? Like, we all know this. Everybody sitting in the room probably has the same problem. We have no attention span. I mean, I lost you guys after I said hello, I like to talk to you about. And then you're gone. We are no different on the other end of the phone. Right? Our attention span probably isn't great. Bottom line up front, tell us what you want us to know. Keep it concise, keep it ordered. 1 to 3 minutes. Tips to staying organized. Use a template. Heck, we give you one. Use it. As Tristan said, create a problem list. Prioritize. And then this, I think, is also important and can be very helpful. When you have a lot of things going on, it is important to request and receive orders based on some type of an approach. That approach on a critically ill train wreck of a patient, as we say, could be an ABCD approach, and we may never get beyond that primary survey initially, airway, breathing, circulation, disability, or on somebody maybe a little bit more stable, via a systems-based approach, like you see here. Now, does that mean that you have to tell me about every single system on the patient? No, you tell me about the ones that are relevant. But you do it in an ordered format. And you talk about all the things that are relevant to the pulmonary system with respect to the ventilator at the same time. Or their sepsis and one antibiotic therapy they're on at the same time. Don't lose the forest for the trees. Commenting on every little guy over there and every little data point is a setup for you missing the big picture. So more keys to success. Again, said this a couple of times now, just trying to drill the same point home. Organize your thoughts prior to calling. I've seen everybody here take excellent notes, but if you're going to write notes, write them in an organized format so you can refer to them and have that rapid consult matrix next to you. Just to sort of scribble this on a piece of paper and then try to read off it is not going to set you up for a successful consult. Bottom line up front, clearly convey the reason for your consult right at the beginning. Again, spoiler alert, when we go upstairs, clearly convey the reason for your call, reason why you're calling right up front. Speak slowly. Right? We're often not sitting at a desk, obviously, with a pen or pencil in our hand and a piece of paper in front of us. What are we doing? We're golfing, right? What else do we do? You get out. You don't work. You golf, right? No, I don't think anybody here golfs. You guys golf? Miniature golf. We're miniature golfing. That could happen. Conclude with the reason for the consult. Again, start and end the same way. And confirm orders and recommendations. Ensure good closed-loop communication. The don'ts, right? Please don't do the following. Information dump, right? This is when you just unload all of this information and then stop talking. Hello? My phone. Hopcom, I think I lost him. Like, no, I'm still here. I'm like, oh, okay. Try not to have verbal diarrhea. Please don't consult without a reason or a question, right? There are other ways to let us know something happened. It would be via a consult. You can still call Hopcom and get the necessary people online. But you're not calling for a medical consult, right? When you're consulting, you should have a question. This is really important. Again, borrowing something from the aviation industry, when you're doing a medical consult, we should have the sterile cockpit concept. Having multiple conversations with your partner, with the sending facility, with the patient, with the patient's grandmother, like, right, is very distracting. You talking to me? You talking to him? You talking to her? Who are you talking to? And who's talking to who? Right? You're not consulting because everything is, oh, hunky-dory, this is great and going well. You're consulting because usually there's an issue. Being able to hear you and understand what is going on is very important. Same way with how we treat an airway. We're doing an airway, nobody's talking. Sterile cockpit. Same thing here. Politely tell people before. Maybe if the nurse is consulting on an SCT call, the paramedic partner or EMT can maybe field some of the other distracting people that are interjecting. Hey, they're on the phone with the medical director doing a consult. What's the question? What's the issue? Please allow them to finish the consult. And try not to sound like this, right? The CBC shows X, the lung sounds are Y, and the metabolic panel shows Z, and by the way, they just got benzos, and oh yeah, their vent settings are this, right? That's how information gets missed because we're not following an ordered, logical approach to the consult. I'll end with this. We know this could be challenging, right? Having a reliable signal, I swear, right? The most important part of the consult, wait, what? Where'd they go? They dropped the call. I can't hear them. It's every other word. Plan accordingly. If you know, right, you're in a basement of somewhere and the reception is poor, think about what your options are. Option one, I guess, to take your cell phone and walk outside. Probably not the best option, right? I don't want the primary patient caregiver who's established patient care to say, oh, I'll be back. Let me go out to the ambulance bay to go make a phone call. Use a landline. Hey, need to borrow your landline to call our medical director on call. But think about this, because if you don't, then you're walking out to the ambulance bay to make a phone call. The other thing that I think is important to make sure you understand is that sometimes no matter what you do, how well you think about it or plan for it, you may not have a reliable signal. And what we don't want to happen in that case is that you don't do something that you know is indicated for the patient just because you can't get in touch with us at that moment. We want you to do what is in the best interest of the patient, right? The golden rule. Do what is in the best interest of that patient, and obviously call as soon as is feasible. Right? A very concrete example, anaphylaxis. Not that you need to call for epi and anaphylaxis, but let's say you did. Patient having clear anaphylaxis, but you can't get somebody. So do I give him epi or not? You know you're supposed to give him epi. Give him the epi. It's the right thing for the patient. We'll talk about it as soon as we can. Lastly, what is our responsibility, right? 3 of us standing here. Our responsibility is to provide you with clear communication. Our responsibility is to provide you with anticipated guidance. So if this doesn't work, do this and this. And if both those don't work, then we want to call back. But it's not helpful to you guys on a critically ill patient that if every time something doesn't work, you got to pick up the phone and call us again. Not helpful. Do this and then this. And if that doesn't work, then call us again. Our job is to ensure safety for you guys and for the patients. And above all of our jobs is to ensure that we deliver Hopkins medicine to all of our patients, no matter where they are. 100% of the time. All right. With that, Bruce, question.
And, well, question, add to the fact that a lot of consults for resolving try to resolve political issues or logistical issues on their own and personal threats and investigation action for time involved. You and I have had a couple, social stress, real time.
Yep. Yeah, so
People forget to call the logistics or the consultation.
yep. Yeah, if we need to be there as an advocate, then that's the reason why you're calling. Let us know that up front. It's important to let us know that up front because if there is some sort of logistical personnel issue, interpersonal communication problem, I am probably, rather than having you go through the X minute long consult, asking Hopcom to pull up the AOC. So everybody's in the loop at the same time about this stuff. What else? Other questions or comments? Kara, please.
I guess sorry if I missed this, but is there like I guess printed paper copies of the rapid consult matrix that we could like take notes on? So like for flight we have like printed out ones with like blanks and like spaces for labs and stuff like that. I use it all the time.
Yep.
So I don't know if that's something else you have.
Yep. Absolutely. We can get you guys printing copies. That way, when you're taking notes, you're not having to take notes on the back of something or a regular piece of paper. You're taking, right, notes next to where the information belongs. Yes?
Yeah.
I love your note taking, by the way. Yes.
What's your opinion on pre-consultation?
It's a great question. So the pre-consult. I would say overall, I don't know if I'm speaking for the rest of the group here, but overall we don't find the pre-consult very helpful. Because, for a number of reasons. One, we don't have all the information, right? Two, we're talking about a theoretical problem that we don't know is going to be an actual problem until we get to the bedside. And three, I think probably most important, I'm not going to make any decision really on patient care until I hear about your assessment of the patient at the bedside. You are our eyes and ears. We trust you. all you're doing is giving information to me that you've heard, which may or may not be either accurate or relevant when you arrive at the bedside of the patient. Sure, you can all think of probably a circumstance where you think a pre-consult would be helpful. I'm sure there are probably one or two out there. But generally speaking, we don't find the pre-consult helpful. Let us know what the active issues are when you get there. Because as you know, things change rapidly. And the reason for why you thought you were going could have nothing to do with why you're actually there when you arrive at the bedside. Great question. Other questions? Yes?
For things that fall outside of our plan,
So that's a great reason to consult. That would be your bottom line up front. I'm calling to discuss our airway management plan because I'm transporting somebody without a secure trach. Period. Right? Give us the pertinent, the rest of the information. Conclude with that reason, and then we will talk about what your airway management plan should be should something catastrophic happen en route. But make it an active, the consult should be an active process, right? Rather than, hey, I just want to let you know about this. I want to let you know about it so we could discuss the airway management plan. Because guess what? Talk about competing priorities. You think you want to pick up a phone and call me or any of these guys when that airway emergency occurs? No. You want to get busy, right? You want to get to work. That's where the anticipated guidance comes from on our behalf. I don't want you calling me when you're trying to deal with an acute airway emergency. I want you dealing with a problem. You can all do it. That's why you're here. What other questions? But I want to make sure nobody else has. Okay. So to clarify another thing that is often confused sometimes, where do ALS, MIMS protocols come into play? Right. So obviously, when there's an ALS transport, right, you're using our MIMS protocols. As soon as we do an SCT transport, we throw that critical care nurse on the ambulance, we are now utilizing our Lifeline protocols. Everybody is utilizing those Lifeline protocols. Okay. Obviously, Bruce, picking on you, if you're running call ALS and there's no nurse with you, clearly you're using the MIMS Maryland protocols. And now you have the nurse, we're now using our Lifeline protocols. Okay. All right. Thank you guys for your time and attention. I hope this was helpful. Let's put this to good use upstairs. Okay. Take your protocol book with you. Consult via the template. Hopefully it'll drive stuff home.